Continuing chapter 34, talking about pediatric trauma emergencies and management now. Unintentional injuries are the #1 killer of children in the United States. Quality of care in the first few minutes after a child has been injured can have an enormous impact on the child's chances for complete recovery. The muscles and bones of children continue to grow well into adolescence. For this reason, coupled with their risk-taking approach to activities, adolescents are prone to fractures of the extremities. A fracture of the femur is rare in pediatric patients, but when it does occur, it is a source of major blood loss. Older children and adolescents are prone to long bone fractures, femur and humerus, because they tend to take more risks during physical activities. Physical differences. Children are smaller than adults, and therefore the location of their injuries may differ from that of an adult in the same type of crash. Children's bones and soft tissues are less well developed than those of an adult, and therefore the force of the injury affects these structures differently. Because a child's head is proportionately larger than that of an adult, it exerts greater stress on the neck structures during a deceleration injury. Children often are injured because of their underdeveloped judgment and their lack of experience. Always assume the child had a serious head and neck injuries. Injury patterns. It's important for the EMT to understand special physical and psychological characteristics of children and what makes them more likely to have certain kinds of injuries. In vehicle collisions, children playing or riding a bicycle can dart out in front of a motor vehicle without looking. The greatest area of injury varies depending on the size of the child and the height of the bumper at the time of impact. Children involved in these type of injuries typically sustain high energy injuries to the head, spine, abdomen, pelvis, or legs. Sport activities. Children, especially those who are older or adolescents, are often injured in organized sports activities. Head and neck injuries can occur after high-speed collisions in contact sports such as football, wrestling, ice hockey, field hockey, soccer, or lacrosse. Remember to immobilize the cervical spine when caring for children with sport-related injuries. Be familiar with your local protocols for helmet removal. Injuries to specific body systems. Head injuries. Head injuries are common in children because the size of the child's head in relation to the body is larger than that of an adult. An infant also has a softer, thinner skull, which may result in injury to the brain tissues. The scalp and facial vessels can bleed very easily and cause a great deal of blood loss if not controlled. Nausea and vomiting are common signs and symptoms of a head injury in children. It's easy to mistake for an abdominal injury or illness. You should suspect serious head injury to any child who experiences nausea and vomiting after a traumatic event. Immobilization. Spinal immobilization is necessary for all children who have a possible head or spinal injury after a traumatic event. Immobilization can be difficult because of the child's body proportions. Young children require padding under the torso to maintain neutral position. At around 8 to 10 years of age, children no longer require padding underneath the torso. You can lie supine on the backboard. Padding will be required along the sides so the child can be properly secured to an adult-sized backboard. Chest injuries, usually a result of blunt rather than penetrating trauma. Chest wall flexibility in children can produce a flail chest. Keep this in mind as you assess a child who has sustained a high-energy blunt trauma to the chest. Even though there may be no external signs of injury, there may be injuries within the chest. Pediatric patients are managed in the same manner as adults. Abdominal injuries. Abdominal injuries are common in children. Children can compensate for significant blood loss better than adults without signs and symptoms for shock developing. Children can have a serious injury without early external evidence of a problem. All children with abdominal injury should be monitored for signs and symptoms of shock, including a weak, rapid pulse, cold, clammy skin, decreased capillary refill, confusion, and decreased systolic blood pressure. If a patient shows signs and symptoms of shock, prevent hypothermia by keeping the patient warm with blankets. If the patient has bradycardia, ventilate and monitor during transport. Here's a graphic for you, kind of showing the differences between children and adults when we're talking about signs of shock and how much blood loss a person can take. Burns to children are generally considered more serious than burns to adults. Infants and children have more surface area relative to total body mass, which means greater fluid and heat loss. Children also do not tolerate burns as well as adults do. Children are often more likely to go into shock, develop hypothermia, and experience airway problems. The most common ways in which children are burned are exposure to hot substances such as scalding water in a bathtub, hot items on a stove, exposure to caustic substances such as cleaning solvents or paint thinners. Older children are more likely to be burned by flames from fire. You should expect possible internal injuries when you see a child with burns around the mouth and face. Infection is a common problem following a burn injury in a child. Burned skin cannot resist infection as effectively as normal skin can. Sterile techniques could be used in handling the skin of children with burn wounds if possible. You should consider the possibility of child abuse in any burn situation. Make sure you report any information about suspicions to the appropriate authorities. Severity of burns. Minor is partial thickness burns involving less than 10% of the body surface area. Moderate partial thickness burns involving 10 to 20% of the body surface area. Severe, any full thickness burn, a partial thickness burn involving more than 20% of the body surface, or any burn involving hands, feet, face, airway, or genitalia. Pediatric patients are managed in the same manner as adults. If the patient shows signs and symptoms of shock, prevent hypothermia by keeping him or her warm with blankets. If the patient has bradycardia, ventilate. Monitor the patient during transport. Injuries to extremities. Children have immature bones with active growth centers. Growth of long bones occurs from the ends at specialized growth plates. Growth plates are potential weak spots. Incomplete or green stick fractures can occur. Generally, extremity injuries in children are managed in the same manner as those in adults. Painful deformed limbs with evidence of broken bones should be splinted. Specialized splinting equipment should only be used if it fits the pediatric patient. You should not attempt to use adult immobilization devices on a pediatric patient unless the pediatric patient is large enough to properly fit. Pain management. The first step in pain management is recognizing that the patient is in pain. Since some pediatric patients will be nonverbal or have a limited vocabulary, look for visual clues and use the Wong-Baker Faces Pain Scale. You are limited to the following pain interventions: positioning, ice packs, and extremity elevation. These interventions will decrease the pain and swallowing to the injury site. Additional ALS interventions may be needed. Another important tool is kindness and providing emotional support. Disaster management. The Jumpstart triage system was developed for pediatric patients, intended for patients younger than 8 years of age and weighing less than 100 pounds. There are 4 triage categories in the Jumpstart system designed by colors corresponding to the different levels of urgency. Decision points include ability to walk, except in infants; green tag, minor, not in need of immediate transportation; presence of spontaneous breathing with peripheral pulse and appropriate responses to painful stimuli; yellow tag, delayed treatment; apnea, responsive to positioning or rescue breathing; respiratory failure, breathing but without a pulse or inappropriate painful response; red tag, immediate response; apneic and without a pulse or apneic with unresponsive to rescue breathing; black tag, considered deceased or expectant deceased. And here are those again. And here's kind of the algorithm for how to put them into the different categories. Child abuse and neglect. Child abuse means any improper or excessive action that injures or otherwise harms the child or infant. Includes physical abuse, sexual abuse, neglect, and emotional abuse. Over 500,000 children are victims of child abuse annually. Most of these children suffer life-threatening injuries and some die. If you suspect child abuse, it is not reported, the abuse is likely to happen again, perhaps causing permanent injury or even death. Must be aware of the signs of child abuse and neglect. It is your responsibility to report to law enforcement or to child protection agencies. As an EMT, you'll be called to homes because of recorded injury to a child. Child abuse occurs in every socioeconomic status, so you must be aware of the patient's surroundings and document your findings objectively. You may be called to testify in abuse cases. It's essential to record all findings, including any statements made by caregivers or others on the scene. Ask yourself the following questions. Is the injury typical for the developmental level of the child? Is the MOI reported consistent with the injury? Is the parent or caregiver behaving appropriately? Is there evidence of drinking or drug use at the scene? Was there a delay in seeking care for the child? Is there a good relationship between the caregiver and the child? Does the child have multiple injuries at different stages of healing? Does the child have any unusual marks or bruises that may have been caused by cigarettes, grids, or branding type injuries? Does the child have several types of injuries? Does the child have any burns to the hands or feet that involve a glove distribution? Is there any unexplained decrease in level of consciousness? Is the child clean and an appropriate age weight for his or her age? Is there any rectal or vaginal bleeding? What does the home look like? Clean or dirty? Is it warm or cold? Is there food? The mnemonic child abuse may help you remember what points you're looking for. And here it is up on the screen for you to review on your own. For bruises, observe the color and location of any bruises. New bruises are pink or red. Over time, bruises turn blue, then green, then yellow, brown, and then fade. Note the location of bruises. Bruises to the back, buttocks, or face are suspicious and usually inflicted by a person. Oh, excuse me. Burns. Burns to the penis, testicles, vagina, or buttocks are usually inflicted by someone else. Burns that encircle a hand or foot that look like a glove are usually inflicted by someone else. You should suspect child abuse if the child has cigarette burns or grid-like pattern burns. Fractures. Fractures of the humerus and femur do not usually occur without major trauma. Falls from a bed are usually not associated with fractures. You should maintain some index of suspicion if an infant or young child sustains a femur fracture. A complete fracture of a bone in a pediatric patient indicates that the child was exposed to a great deal of traumatic force. Shaken baby syndrome. Infants may sustain life-threatening head trauma by being shaken or struck in the head. This life-threatening condition is called shaken baby syndrome. There is bleeding within the head, damage to the cervical spine as a result of intentional forceful shaking. An infant will be found unconscious, often without evidence of external trauma. Infant may appear to be in cardiopulmonary arrest. Shaking tears blood vessels in the brain, resulting in bleeding around the brain. The pressure from the blood results in increased intracranial pressure, leading to coma and/or death. Neglect is the refusal or failure on the part of the caregiver to provide life necessities. Examples are water, clothing, shelter, personal hygiene, medicine, comfort, and personal safety. Children who are neglected are often dirty, too thin, and appear developmentally delayed because of lack of stimulation. You may observe such children when you are making calls for unrelated problems. Report all suspected cases of neglect. Symptoms of other indicators of abuse. Abused children may often appear withdrawn, fearful, or hostile. You should be concerned if a child does not want to discuss how the injury occurred. Occasionally, the parent or caregiver will reveal a history of accidents. Be alert for conflicting stories or lack of concern from the caregiver. The abuser may be the parent, caregiver, relative, or friend of the family. EMTs in all states must report suspected abuse. Most states have special forms to do so. Supervisors are generally forbidden to interfere with the reporting of suspected abuse. Law enforcement and child protective services will determine whether there is abuse. It's not your job to prove that there's abuse. Sexual abuse. Children of any age or either gender can be victims of sexual abuse. Maintain an index of suspicion regardless of the patient's social or economic situation. This type of abuse is often the result of longstanding abuse by relatives. Assessment should be limited to determining the type of dressing any injuries require. Treat any bruises or fractures as well. Do not examine the genitalia of young children unless there is evidence of bleeding or that an injury that must be treated. Do not allow the child to wash, urinate, defecate before a physician completes a physical examination. It's a difficult step, but it's important to preserve evidence. Ensure that an EMT or local police officer of the same gender remains with the child, unless locating one will delay transport. Maintain professional composure the entire time. Assume a concerned, caring approach. Shield the child from onlookers and curious bystanders. Obtain as much information as possible from the child and any witnesses. Child may be hysterical or unwilling to say anything. You're in the best position to obtain the most accurate first-hand information. Record any information carefully and completely on the patient care report. Transport all children who are victims of sexual assault. Sexual abuse is a crime. Cooperate with law enforcement officials in their investigations. We'll go ahead and stop here.